Anti-NMDA receptor encephalitis is one of the most fascinating and most misdiagnosed conditions in neuropsychiatry. It can look like schizophrenia, bipolar, delirium, or epilepsy, depending on where and when you meet it. I wrote this article for the Journal for Nurse Practitioners to make this diagnosis more visible to the NP community because early suspicion and treatment literally changes lives. In this presentation, I'll walk you through the article that explains what anti-NMDAR encephalitis is and why it gets missed, and what can be done to recognize it earlier. If you see a patient with new-onset psychosis, catatonia, or unexplained movement disorder, think anti-NMDAR first, not last. Let's start with why this condition flies under the radar. Most cases begin as a first episode psychosis, so patients land in psychiatry, not neurology. The problem, every week of delay in diagnosis increases the risk of ICU admission and long-term cognitive decline. EEG may show the extreme delta brush pattern, but only in about 1/3 of patients. MRIs are normal in half the time, so the diagnosis hinges on clinical suspicion, and that's where NPs from primary care, psychiatry, and acute care settings can make a difference. Don't wait for antibodies to confirm what your clinical gut already knows. This is an autoimmune encephalitis caused by antibodies that cross-link and internalize NMDA receptors. When those receptors disappear from the synapses, the brain essentially loses its ability to regulate excitation and inhibition, producing a storm of psychiatric, cognitive, and autonomic symptoms. You'll see everything from agitation and hallucinations to seizures and dysautonomia, all in one patient, often within weeks. This isn't a psychiatric disorder or mental illness. It's synaptic failure masquerading as psychosis. The incidence of anti-NMDAR encephalitis is estimated between 0.17 and 2.3 cases per million, but studies show it may reach approximately 3 per million in Black populations. Among women, particularly younger adults, ovarian teratomas are more frequently associated with this condition and may influence relapse risk. The key point here isn't about social policy, it's about clinical vigilance. When we understand how presentation and risk vary across patient groups, we improve diagnostic accuracy and ensure timely treatment for everyone. Clinical vigilance, not assumptions, reduces missed diagnosis. In pediatrics, the picture is often seizure heavy, status epilepticus, regression, or mutism. Adults tend to present with psychosis, paranoia, catatonia. Geriatric patients may look delirious with rapid cognitive decline that mimics dementia. One disease, three faces. So understanding age-related patterns prevents years of mislabeling and mistreatment. The same pathology wears a different mask at every age. The 2016 Grouse criteria make this straightforward. If a patient develops rapid onset symptoms from 4 of 6 categories, psychiatric, seizure, movement, language, autonomic, or consciousness, and has either EEG or CSF abnormalities, you already have a probable diagnosis. Serum antibodies will miss about 15% of cases. CSF testing is definitive, but the key point is don't wait for the results. Start immunotherapy when the criteria fit. Time is synapses. You treat on suspicion and confirm later. First-line therapy starts with IV steroids, IVIG, or plasmapheresis. If there's no response, move to rituximab or cyclophosphamide. Rituximab is preferred due to tolerability. And if a teratoma is present, resection is essential. It can make the difference between relapse and remission. The most dramatic improvements happen in the first 6 months, but full recovery can take up to 3 years. Treat early, treat aggressively, and expect recovery, even if it's slow. Screen all reproductive age women for ovarian teratomas, especially black females. Avoid NMDA antagonists like ketamine during anesthesia. Plan long-term rehab because cognitive recovery is gradual and relapse surveillance matters. And above all, remember, psychiatric symptoms don't exclude neurological causes. Every psychiatric crisis deserves a neurological second look. As nurse practitioners, we occupy a unique position within the healthcare system, bridging disciplines, synthesizing perspectives, and seeing the entire patient. Our generalist foundation gives us a panoramic view. We can notice when psychosis doesn't quite fit, when catatonia coexists with tachycardia, and when a young woman's agitation suddenly spirals into seizures. That's when your diagnostic curiosity can become life-saving. We're often the ones who advocate for diagnostic interventions, a lumbar puncture here, a neurology consult there, or one who questions a premature psychiatric label and push for early immunotherapy. And when the acute crisis passes, the work doesn't end. The nurse practitioner will guide the family through the long recovery, coordinating cognitive rehab, management of autonomic instability, monitoring relapse, and offering the kind of anticipatory guidance that restores both safety and hope. I wrote this article to equip you with pattern recognition and confidence. The paper's in the Journal for Nurse Practitioners. It lays out diagnostic criteria, treatment algorithms, and a lifespan-specific variation that can be appreciated. Practical tools that you can apply immediately in your practice. So please read it, share it, use it to teach your peers, to mentor your students, and to recognize the next patient who walks into your clinic labeled psychotic when in truth her brain is under immune attack. Because when an NP recognizes anti-NMDAR encephalitis early, that's not just good care, it's a rescue mission at the cellular level.